All right. Okay. So let's see. So these three over here are my therapists, and they're here to hang out with us. So welcome. I'm glad you guys are here. I'm glad if anyone's watching on YouTube Live, I'm glad they're here as well. My name's Dave Butler, and thanks for coming. We'll probably have a few that come in after this, but we're going to talk about scoliosis. Just a little bit of introduction. So this is Corey over here. He's one of my PTs. Brad is also a PT, and then Janessa's our PTA here. They're all certified and specialized in scoliosis and spinal deformities. So they're here to answer any questions. They're here to help me out when I mess up or I forget what I was going to say, things like that. So, yeah, let's just kind of get into it. So today we're going to talk about living with scoliosis. I didn't want to just talk about scoliosis. I mean, heck, I could talk about scoliosis for a long time. I'm kind of a scoliosis nerd, as my wife tells me. But we can get as deep as we want to go into scoliosis. But really, what I wanted to talk about was living with scoliosis. So adolescents to adults. This isn't just about adults. This isn't just about adolescents. I've done workshops in the past about just adults or just adolescents. So today I was like, let's do one just about scoliosis in general, because there's a lot of overlap, but there's also a lot of differences. And we have to be aware of those differences, and it does affect what the rest of our lives look like depending on what stage you're in. So I want this to be empowering, educational, and actionable. You guys are here because you probably hope to get something out of this. I hope to provide something out of this as well. So, and I do think there are more options than you think. A lot of times with scoliosis, it feels like you don't have any options. And I'm hoping to open that up a little bit so that we can see what options there actually are. So a little bit about me. I put this one here because we just opened so this side wasn't a part of the clinic until probably the last month. And we have rooms with cold plunges and saunas in them, and a massage therapy room and things like that. So before you leave today, you have to cold plunge, and then you can leave. Just kidding. I won't have you cold plunge. But this was last year. We did a cold plunge in the river up American Fork Canyon, and that was so cold. It was snowing on us. It was beautiful, but that was so cold. We do not keep our cold plunges that cold here, because whew. But this is my family up here on the left. Last year we just added one, not with a baby, but with a son-in-law, which is a whole new world. Holy cow, that's different. I was born and raised here in Utah. I'm married with 4 kids. My youngest is 14 now, and my oldest is 21. This is the one that just got married. And yeah, I founded Align Therapy in 2015 because I saw a need that there wasn't any specific scoliosis treatment options in Utah. So back in 2015, I mean, no one was really doing conservative scoliosis treatment. And I remember as a new PT, I was working up in Draper. So I graduated from PT school in 2007, and I was working up in Draper, and a mom brought her daughter into my clinic, and she said, "Do you do the Schroth method?" I'm like, "The what method? Well, I don't know what you're talking about." So I researched it a bit and found out what it was, but at the time it was really only taught, I think there's only one place, actually no places in the US at that time, that was teaching it. You had to go to Barcelona or you had to go to Germany to learn that. And I was a new PT, and I think it was in my first year even, and I'm like, I don't think I want to really dive into this. I'm still trying to get my feet wet as a PT. And so it kind of stuck with me. 8 years later, when I got sick of the corporate structure of physical therapy in that company, I was like, what would I want to do if I went out on my own? And And my mind went back to that. I was like, you know, I should really look into this, because that was something that seems like it's a need, and can I fill that need? So that's how I started Align Therapy. I started with treating a lot of runners and triathletes. That was one of my specialties as well, and then gradually building up the scoliosis side. So I thought it would be a nice little side project, a little side gig, but it turns out that now, I mean, Janessa, what would you say, 85% of our patients are scoliosis patients?
At least scoliosis or spine related.
Some spinal issue or deformity, which is really cool. It allows us to get deep into something, and it allows me to become the scoliosis nerd that my wife says that I am now. So I've been a scoliosis specialist since 2014, and what I mean by that is I've been trained and certified in a scoliosis method of treatment. The Schroth method is what I started with. And I'm a member of SOSORT. SOSORT's the International Research Society for Scoliosis. And we have a meeting every year, and we go over current research, and we discuss practice guidelines and things like that. So this year it's in Italy. It's too bad I have to go to Italy for that, but it's great information, and it keeps me up to date on things. PSSE Association is a new association for physiotherapeutic scoliosis specific exercise. You see the reason for the acronym. And that encompasses the Schroth method, the SEAS approach, the Lion method, I mean, all kinds of different methods. So I'm a member of that as well, and I'm board certified in orthopedics since 2009. So I used to treat mostly knee replacements, ACLs, and shoulders, and then I transitioned into what I really am passionate about, which is the spine and spinal deformities. So, so that's a little bit about me. A little bit about these three over here. Corey joined us, how many years ago was that? Almost 8 years ago. And he's trained same level as me in scoliosis treatment. He's also, he also specializes a little bit in McKenzie method back treatment, as well as he's my shockwave expert. And that's really cool. I don't think we'll talk about that today, but yeah. Brad's been with us for 2 years, and he's just been killing it. He just got his, finished off his dry needling certification, and that's pretty cool. He said he poked someone's TMJ yesterday and had an amazing result. How's that sound, putting needles in your jaw? No? No takers? All right. And then Janessa's been with us for...
It's almost 6 years.
6? Are you serious? Holy mackerel.
Time flies.
She had a baby during that time, so I think I reset. I reset my timeline at that point. So, and she just got back from New York. She did a training in New York for a week on the Schroth method. So, it's, you know, we've got quite a few years of experience here. But I really want to know. I want to know about you guys. I want to know what your background is. Maybe not your whole background. You don't have to tell me your whole background. But what are you hoping to get out of this? I want to make sure that I provide what you guys want to hear about. I mean, I have slides, and I'm not going to change my slides real quick, but I'm going to try to get to all the things that you guys want to talk about. So,
if you want to just tell people on the video, I'm monitoring the chat.
Oh,
so if
cool.
they want to ask questions in here, I can.
So anyone online, you can ask a question. Janessa will bring that up. We might not be able to answer it immediately, but we'll have time for question and answers. So, so we'll start here. What do you want to get out of this?
Well, I've tried a lot of things to help my scoliosis. I grew up swimming, which they said helped my scoliosis, but I didn't know I had scoliosis until I was 22.
Oh.
I was already a school teacher at that time.
Right.
So I tried something where I wore like heavy things on my head, like a crown of weight and a weight on one side of my shoulder, and I had to lay on this cheese wedge thing for like a long time every day.
Sounds exciting.
Some sort of
like a traction.
neck in the traction thing. And this was done by actually a friend of mine that I went to high school with, and he became a chiropractor, and it didn't work. In fact, it got worse. Even though I was very diligent. And then I did a soft core brace for 3 years. That worked. The pain went away, but now it's coming back.
Okay.
And I just want something permanent, but I want to be able to do it by myself. And I kind of worry, like, I don't know much about the Schroth method, but I did voice therapy because I have muscle tension dysphonia. And I couldn't understand what they were telling me to do with my voice. And I worry about that with the Schroth method, like, you know, do this and I can't feel it. I don't get it.
Right.
But I just want something I could do at home so I'm not in pain and so the curve doesn't get worse so I could just age without pain.
Okay. That would be great,
Yeah.
right? Let's age without pain. Okay, cool. I have that down.
Because I'm old, way back in the day, like in the late 60s, when they would check you at school. And so I think I
Right.
was in the 6th grade and they said, you have scoliosis. My mom took me to the doctor. They said, yes, we want to put a brace, you know, those metal braces with the neck thing.
Right.
And I said, no way, because there was a girl at our school that had that and everybody made fun of her. And I said,
Corey, can you see if there, oh, there is somebody. Come on in, have a seat. Sorry, go ahead.
I said I won't do that, so we did nothing, and I've done nothing since then. And so I'm just curious to know what there is,
Okay.
what options there are.
Okay, curious to know options. Awesome. Thanks for coming in.
Sorry.
Just so you know, we are on YouTube Live as well. So, you know, you can share what you want. You can not share what you want. Don't want. Okay. And we're just talking about what you guys want to get out of this. Okay. So, curious about other options and what there is available.
Right.
Awesome.
I would say very similar to her. But,
Okay.
I was a school teacher, and I think that's what started my scoliosis going into a curve. I didn't get it or wasn't diagnosed until I was quite old. But I ended up with a sciatic so bad that I had to have spine surgery. So but I still have issues. And I
Right.
would like to get some of the pain and movement back.
Yeah.
That's where I'm at. So.
Okay. So look.
Exercises at home that I can be consistent with and
Okay.
relieve some of my extra pain.
Okay. Awesome.
I have not had it quite like you ladies. Once upon a time, a physical therapist told me I had scoliosis, and I was like, oh, that's interesting, okay. But I was there for something else, and we didn't really deal with it. I do, in my family, my father had severe scoliosis.
Oh.
I mean, he's
Yeah.
super twisted. I know they've said my brother's had it. But just becoming aware of your clinic and learning about it, I feel like there's a lot that can be done that I'm not familiar with. And since it is a thing, not only with me, but also it's a thing in my family, like even with little kids and stuff. And so I would really like to learn the options. Something that I don't think is necessary, I don't know if it's related to scoliosis per se, but the spine, I'm like getting this kind of posture and the whole little thing.
Okay.
And I don't like that, and so I would love to know how to fix stuff like that.
Okay. That's great. I mean, as we already see, we're all at different places. You know, definitely different places. Right back there.
So I was diagnosed with scoliosis, I think, when I was 7 years old. And they told me to monitor it, and that if I got any taller, then it would probably pose an issue. I got a lot taller. Live with it.
Well, you're only 7, right?
Yeah.
Oh, man.
So I've tried physical therapy. I used to tape my back a lot, and that seemed to help a bit. But every week I'm dealing with a new pain somewhere,
Yeah.
a new stiffness, and just want to try and learn how to manage it better and how to take care of it so that it doesn't cause me as much pain and keep me up at night.
Okay. All right. All right.
So I wanted to, like, learn about adult onset scoliosis and like whether like things like massage or muscle knots or exercise or stretching would help. Or what else can you do at home versus just more besides professional therapy?
Yeah. Okay.
Yeah, I think
what I would like to get out of this is mainly, like everyone else said, just like exercises that can help more with like just imbalances that I've
Okay.
seen, and so that I can do all the other things that I want to do, like physically.
Yeah. Great. And imbalances are definitely something that we're going to talk about. How'd that stop? That is not what we're going to be doing today. So,
Well, I'm here because I have a 14-year-old with scoliosis.
okay.
They found she's gone to all the doctor's appointments. They've never diagnosed her with any. They'd always check her spine and everything. But then
Yeah.
we had her tested for asthma, and when they looked at the X-ray for that, her doctor said, "Oh, she has scoliosis." So she has a 30% curve.
Okay.
She's been wearing a brace for a little over a year. They're anticipating that her growth plate is on the verge of closing. So we have an appointment at Shriners in a couple weeks to see if she can wear the brace longer or if she's kind of at her peak.
Right.
It doesn't seem to affect her too much except for aches and pains. same
So she
with
does
the
have
one
aches and
over there.
pains.
Yeah, I just thought maybe there's some stretches I could, help her do or something to stay.
Yeah.
She just feels tired. By the end of
Right.
it, like, holding it in a certain position. So.
Okay. Yeah, we'll definitely be talking about that. Let's see if I can get this back up here. Aha, there it is. Sorry, this is a new TV to me, so what's that?
We're still training.
We're training it. Yes, it's in training mode. So yeah, we're gonna hopefully cover all those things. Mainly, I want to talk about. I want to touch on what scoliosis is, but I think most people in here know what scoliosis is. But there are some specific things I want to talk about that help us understand what treatments we should be doing based on the curve and the curve type and things like that. So, yeah, these are all great questions. I'm glad you guys are here. Well, if I don't get to your question, please let me know. I want this to be as interactive as possible because I want you to get out of this what you want to get out of this. So, there we go. Okay, so let's talk about what scoliosis is. It's discussing what scoliosis is helps us to understand how we treat it. So scoliosis is a three-dimensional curve of the spine. I think that's important to understand. It's a curve, and most of the time we see an X-ray like this, and that's, I don't know, raise your hand if this has been your experience. You're diagnosed with scoliosis, they do an X-ray, they pull that up, and they tell you that this is your scoliosis, and they don't really do any physical examination, and they don't push on anything, they don't touch anything, and they treat it based on that. Yes?
Yes.
The degree, yeah. They want to know the Cobb angle, right? And so scoliosis is so much more than the Cobb angle. There's a rotation associated with it too. That's why we see the ribs are different. That's why we see the shoulder blades sitting different, all of those things. And that rotation is probably the thing that people notice the most, and probably where a lot of the pain comes from. So if we don't think about it as a three-dimensional problem, and we just think about that, it's like, oh, I just need to bend sideways. But if you have two curves, which side do you bend to? And it also usually creates, in adolescents, it'll create a flatter upper back, so what's called a hypokyphosis. And in adults, it can create that, but it can also make you start to lean forward. And something that someone was talking about with rounding of the upper back.
Is it because the muscles on one side is like tighter than the other, it creates it to curve, or what's the cause?
It's a great question. We'll talk about cause in just a minute, but a lot of it's idiopathic. We don't know the cause. I think it's always funny that sometimes when I talk to teenagers, I'm like, idiopathic. They're like, well, that sounds dumb. It's like an idiot. Well, yeah, we don't know what's going on, why it's actually there. It affects 2 to 3% of the population, most commonly we associate scoliosis with adolescents. It's the screening that you had in school, or it's, going to your pediatrician visit and they notice something. But it's actually more common in adults. If you think about that, we have adult onset scoliosis, and we also have adolescent onset scoliosis. Both of those are lifelong problems. And so we just add more and more to the scoliosis community as we get older, because it can develop later in life as well. And there are many varieties of scoliosis, and just like snowflakes, no two curves are the same. I've seen, I don't know, I've been doing this 11 years. I don't even know how many scoliosis spines I've seen, and literally they're all different. They might have a same curve pattern, but they have different problems associated with that. And so I think that's something to keep in mind. There's not a set of scoliosis exercises for all scoliosis patients. I know, it's a bummer, right? It's like, just give me the 5 things I need to do and I'll do them, right? It's not that simple. I mean, I've seen people with curves up around 110 degrees, and I've seen people with curves at 7 degrees, and sometimes the one at 7 degrees has more pain than the one at 110 degrees. Isn't that crazy? So pain it's not correlated with the size of the curve. Not totally, but curves over 30 degrees tend to have more pain. We've seen that. So what causes scoliosis? Most of the time it's idiopathic, but there are multiple factors that are involved in this. So we have genetics. Sounds like maybe there's some genetic component to some of the curves in here, right? So family history, I've treated almost full families where the mom has scoliosis, the grandma has scoliosis, and the mom's 3 daughters have scoliosis. So strong genetic correlation there, but then I've also seen scoliosis curves where there's no family history, or none that they can recall or remember. Growth spurts, we already heard about growth spurts. Did you try not to grow when you were 7? Were you like, I'm just gonna try not to grow? So rapid bone growth during adolescence can be a trigger for this. That's usually when we see it develop. But in women, menopause and the hormone fluctuations and bone fluctuations, that can also be a time where we see progression of the curve. So there are multiple times during our lives when progression can happen. Later on, also with degeneration of the spine, we can see progression of the curve as well. Muscle imbalances. Muscle imbalances usually aren't the cause of scoliosis, but we do see muscle imbalances because of scoliosis. Most of the scoliosis cases that I see, and you 3 can correct me if I'm wrong, they start in the bone, and the muscles react because of what's happening in the spine. And so we either get degeneration as we're older, and that tips the spine a bit and creates a curve, or we get unequal growth during adolescence, and that starts the cascade. Yes, no? All right. They're supposed to correct me if I'm wrong on any of this. Neurological factors, we have neuromuscular curves that are a result of nerve problems. Those aren't that common, but there are causes like that. I've seen curves because of kids that have heart surgery when they're really young. Scar tissue in there sometimes will pull and cause an imbalance, and then it sparks off that cascade. So, and then there's congenital. I mean, we could talk about a few different ones, but those are more rare. That's usually what we're not talking about here. So what are you noticing? Let's talk about adolescence. In adolescence, a lot of times we're noticing that the shoulders or hips are uneven. So if you notice on her definitely her hips are uneven. She actually had a leg length difference on the right side. That created a curve in her lumbar spine. But then it's like chicken or the egg. Did the scoliosis start first, and that created a little more of a leg length discrepancy, or not? One shoulder blade might be sticking out. clothes fitting unevenly, and mild back discomfort or fatigue. In my adolescent patients, they usually don't have a lot of pain. Like, it's not debilitating pain. They might have some soreness, some achiness. Sure, there are the outliers with that, but I would say, what would you guys say, 20% of our adolescent kids have pain? Maybe 30? Yeah. Most of it's sitting, maybe a postural component to it, you know, things like that.
It's usually less.
Yeah. Clothes fitting unevenly is something actually that I hear a complaint of more later in life, because, well, maybe not later in life. Dress fittings for dances in high school, they're like, ugh, I can't find anything that fits right because something's off. But then later in life, I usually hear that, you know, you're either having to hem your pants differently, or things sit differently, or putting your purse on one side, it slips off, so you have to put it on the other side. I mean, all these things are things that we might notice. As far as adults go, chronic back and hip pain, that's probably the biggest reason that I'm seeing someone for scoliosis in adults, is because they have pain. And it often worsens over time if nothing is done. I mean, this is a progressive condition. This is not something that, you know, thinking about other conditions that we see in physical therapy, like plantar fasciitis. Anybody know someone with heel pain? So plantar fasciitis sometimes can come on and then run its course, and then like in a year it goes away. Sometimes it doesn't. And then it comes back. So some conditions come on and then they go. We just need to wait them out sometimes, you know. Scoliosis isn't something that if we wait, it goes away. So unfortunately, there's no fix for scoliosis. It's with us. Postural changes in adults, we sometimes can see more of a curve. In this picture, you can see her pelvis is shifted more to the left, and that creates, so in someone like this, a common problem is to see hip pain on the left side, because their pelvis is shifted that way, and that's further away from their center of gravity, and so it has to work harder when they walk. Another big thing that I hear from adults is height loss. Anybody in here lost height? Yeah, okay. So well, we lose height as we age anyway, right? If you think about each disc, if each disc loses a millimeter of height, how many discs do we have? I'm just kidding. So let's say we have 20, but that's like 2 centimeters just if we lose a millimeter from each disc, and that's normal with aging. But usually if we're seeing a lot of height loss, that usually is indicating a progression of the scoliosis. So in kids that are growing, if they lose height, that's a huge red flag that their curve is progressing, because they should be growing. And if they're not growing, that's a concern. With adults, I think more than adolescents, they're self-conscious about how clothes fit, their activity level, you know, just the imbalances. I mean, we talked about muscle imbalances. Sometimes that's causing pain, sometimes that's causing something that, you know, you go on vacation to Mexico, not right now though, don't go to Mexico right now. And you're in a bathing suit and you wonder if people are noticing your scoliosis curve. I mean, that's a real thing. It's a thing that we deal with all the time. Anything else, adolescents or adult-wise, that you guys are noticing? Like, what do you notice?
I have this big old knot. I don't know if it's a knot or what, but right here, and I get like tension headaches every day at the end of the day. And
Okay.
it's been here for years, and I think it's because like there's an imbalance in my neck. Like I don't know what's going on, but
Yeah.
massages don't get it out. I've tried like a suction cup. I've tried a lot of different things, and it's like muscle knots and doesn't seem.
Yeah, and usually what we're seeing with scoliosis-related pain is that it's on one side and not the other. Not that it has to be one side or the other, but I mean, chronic low back pain, we all know someone with chronic low back pain, right? And a lot of times that's both sides. But if you have scoliosis and the pain is on one side more than the other, then there's a good chance that that's related to the scoliosis curve because of the imbalance that happens. So yeah, I think that's a good point. Those knots can be, because the underlying problem isn't being addressed, the imbalance is still there, so it's just going to come back, right? So, yeah.
So in a case like hers, if you resolve the muscle knot, does it mean it's reversible? Or are there other types of scoliosis that's reversible, or most of them are just trying to prevent progression?
Sometimes we'll see them reduce. In adults, that's not as much as in adolescents, but we can see that happen. So if the muscle knot reduces and it doesn't come back, maybe that means you're addressing your posture or the underlying issue a little bit more. I don't know of any studies that show that scoliosis can be fixed. I mean, even surgery doesn't fix it. And so usually it's learning to manage it and learning to address the underlying problem so that the symptoms don't come back. Good question. Yeah.
I have a question on the chat, just from this guy, DRD7706. He says, my son is 22 years old with mild scoliosis, kyphosis, and lordosis. Please suggest treatment. I think you're about to get there.
We're going to get there, yes. So, I mean, that's a really common diagnosis. I mean, it sounds like it came on during adolescence. And yeah, we're definitely going to get there. Thanks for the question. Okay, anything else before I move on from here?
I just have a question.
Yeah.
Like with adults, are scoliosis and like osteoporosis related, or are they two separate issues?
Two separate issues. Osteoporosis can affect scoliosis though, because the bones have less density, and so if there's degeneration in the later years, we usually see it degenerate a little more, a little faster, but usually they're separate. You know, you can have one without the other, definitely. Any other questions with that? Okay. So moving on here, a common fear is, will this get worse? I think that's the thing that keeps the parents of my teenage patients up at night. It's the thing that keeps a lot of my adult patients who have progressive curves up at night. Will it get worse? This is kind of a tough thing under like this cross thing, but really what this means is the earlier action is taken, the more tools are available for both adolescents and adults. So if we put it this way, if we wait until a curve is bumping up against surgical range, we don't have as many options. If we address it before that, we have more options. Does that make sense? Say adults and adolescents is the same thing. If we wait too long, then we start to lose some of the options that could have been helpful to stop that. Since we don't have something that fixes the curve, the bigger we let the curve get without addressing it, the harder it is to back up the train. So,
I have another question on the
yeah.
chat. This one's from Lewin Games 315. They say, are there types of sports that you can do to help rein in the progression? Like, do swimming, climbing, other sports help? Just with that last slide where you're talking about actively addressing it.
So, it's interesting. When I first started practicing, it's kind of at the tail end of this, but providers were still suggesting that kids should pick up swimming because it was lower impact, right? And I still hear that occasionally from some surgeons. I have a huge problem with that because there was actually a research study that showed that swimmers have more rotation in their back, and so we see that increases actually. But we're also doing, especially adolescent girls, a disservice because we're telling them to do something lower impact. We're not building as much bone density, and then we deal with an osteoporosis problem later in life. And we're not teaching the body how to support itself against gravity. Yeah, you're being active, but then you get out of the pool, gravity comes back eventually, right? And so that creates, I want you to be active and healthy. That's not a problem. And if you like to swim, great. But we do need to do some things that are addressing weight bearing. You know, that's how we live, right? Cool. Any other questions before I move on to this? So we classify scoliosis curves in 3 categories. We have mild scoliosis that's under 25 degrees. Under 10 degrees, we don't really call it scoliosis because it could have just been how they were standing in an x-ray or something like that. So less than 25 degrees, those are mild. We monitor those. We do scoliosis-specific exercises, and we focus on preventing progression. If it's a young kid, if I saw you at 7 and your curve was under 25 but over 15, then I might consider bracing, but most of these mild curves we don't consider bracing in adolescents. In adults, I don't usually brace through all of these stages, and we'll talk about why on that. Moderate curves, 25 to 45 or 25 to 50, in that range. We do exercises, scoliosis-specific exercises, possible bracing if they're adolescents and they're still growing, like you know. And then these are most responsive to active intervention. So we want to actually do something because we know that these curves are going somewhere and they're not going where we want them to go, right? Over 45 degrees, those are, I usually send for surgical consultations, especially in adolescents, because this is a curve that will continue to get worse. Exercise plays a key role, I think, still in those bigger curves. Like I said, we see patients in the clinic who have big curves. Maybe they're not surgical candidates. Maybe they don't want surgery and they want to wait as long as possible. And so there's still that role to play. But the reason that curves over 45 degrees in adolescents are surgical curves is because those curves tend to keep progressing even after they're done growing. So it's just a physics thing. If you have a bigger curve, gravity has more pull on it, and there's more progression later in life. So surgery is not for pain relief. So it's not like I have a 30-degree curve and I have back pain, I need to have surgery to reduce the back pain. That isn't, a surgeon that does that surgery should be shot. Maybe not shot. This is on YouTube. I would be careful. They should lose their license, at least, right? Because that is not the indication for scoliosis surgery. I take that back. Surgeons should not be shot. I know. We're going to get some comments about that one. So regardless of the curve size, movement and strength matter at every stage of scoliosis treatment. My least favorite thing with scoliosis treatment is wait and see. How many of you were told wait and see? Let's wait and see if it gets worse. Well, it got worse. What should we do now? Well, let's wait and see if it gets more worse. Okay, that sounds like a great treatment plan. Let's wait and see if it gets more worse. So I think there's a lot more that can be done than the wait and see approach. So common treatment options, we'll talk about these a little more specifically. Bracing. Bracing usually is adolescents that are still growing, 25 to 45 degrees, maybe past the 45-degree mark if they still have growth and they're not a surgical candidate. But bracing doesn't seem to have as much benefit in adults. There hasn't been much research done on adult bracing. And I think there's multiple reasons for that. Some of it is that there's just too many variables in adults. I mean, we have osteoporosis then, we have other issues. Adults don't tolerate bracing like kids do. Kids are more flexible. They can tolerate being pushed in a brace. Adults are usually more stiff. They usually have less tolerance to pressure, especially on the ribs. And can create rib deformities in adults. They're not as springy. So we usually don't do bracing in adults. There are some braces that I'm starting to be a little more open to. The spine core brace has been around for a while. My problem is it's hard to put on correctly and that kind of thing. And there's not a lot of research on it. Maybe I'm wrong on that, and someone online is going to correct me. There's the Scoliosis Smart Activity Suit that we've been hearing about more from one of our patients that can be helpful as well. So there are options in adults. The one that you'll see a lot online is called the Aspen brace. It's a back brace that has a little outrigger that pushes here and here that's supposed to help correct for that. Not my favorite. It is really hard to customize. And with everyone's curve being like a snowflake and all being different, it's kind of hard to fit that correctly. PSSE, who remembers what PSSE stands for? None of you three, you already know. So it's physiotherapeutic scoliosis specific exercise. PSSE just means scoliosis specific exercise, basically. Like Schroth. It's best for all ages and curve sizes. We can use it with anyone with a scoliosis curve. And the goal is to strengthen, correct, maintain, improve body mechanics so that it doesn't get worse. General exercise in yoga and Pilates and things like that, it can be helpful. I mean, mild curves, it can help to create some strength, but really that hasn't been shown to change the trajectory of a curve. So if we're really trying to address the curve, yoga, Pilates, general exercise, personal training, it doesn't really address the curve. So we'll talk more about that. So the Schroth method is something that we do here. I've been doing it for 11 years, and we've been to a lot of training. It's kind of crazy how long the training is for the Schroth method, but it's a three-dimensional exercise approach. Remember, we have a three-dimensional curve. So we're addressing the Cobb angle. We're also addressing the rotation. We're addressing the postural component, whether it's too straight or too rounded. And it's been researched the most out of any of the scoliosis treatment methods. When I started this clinic, I wanted to do scoliosis treatment. I wanted to do it backed as much as I could by research, and this fit the bill, because at the time it didn't have a ton of research, but it had more than anything else. And now, I mean, heck, every month there's more research on Schroth method exercises for scoliosis. It uses corrective breathing, so we use rotational breathing exercises to open up the concave side of the curve to address. So breathing, we already talked about breathing sometimes is a challenge to learn, right? Even though we do it every day, multiple times. Learning corrective breathing, I mean, I would say our patients as young as 8 or 9, wouldn't you guys say, can learn some corrective breathing. It's a little hard with those 8-year-olds, 9-year-olds, but definitely as we get into 11 and 12-year-olds, they're really able to learn that. Our adults even learn it, but it does take some work to learn. Postural correction, so we definitely work on postural correction with the Schroth method. That's the whole goal, is to reduce the imbalances. And then muscle activation, we activate the muscles to try and support the spine in a better alignment. So that's the Schroth method. It's been around for over 100 years now. It was like 1920s is when it came out. Katerina Schroth noticed she had adult scoliosis, and she noticed different exercises improved the look and feel of her scoliosis curve. And she started to develop a treatment technique, and her daughter kind of ran with that and developed a program with that. So that's the history of the Schroth method. Scoliosis-specific exercise, there are different methods. So there's the Schroth method from Germany. There's the SEAS approach from Italy. Very different. Those two are very different, but they're still postural scoliosis-specific corrective exercises. There's a side shift method from England. There's a Dobomed method, which I haven't heard. I don't think it's been researched, from, I think, the Dutch or something like that. But there are different methods. I don't know why they're all in Europe. It just seems like the Europeans are really jumping on this. There's a method coming out in China, and we'll have to see how that goes. But it works. If we're trying to address, we already talked about, knots that come on that aren't going away, or they just come back quickly because of the underlying problem. If we don't address the underlying problem, then we're not really addressing the scoliosis. And so we can see it reduced pain in adults, it slows or halts progression, improves posture and confidence. I actually have had patients come in just like they have no pain, but they just want to feel more confident in what their back looks like. Not feel like their shoulder blades is poking out as it is, and that type of thing. In adolescents, there are some studies that show an improvement in the curve. So sometimes 5, sometimes 10-degree reductions in the scoliosis curve. That's not what we promise our adolescent patients. They're not coming in and we're saying, okay, we can reduce this by 10 degrees. There are a lot of factors, and some people don't see a reduction. But the main goal is to halt progression of that curve, to stop it where it is so that it doesn't continue to progress. And yeah, if that happens, that's a win. Even in adults with a curve that's getting worse. If we can stop it in its tracks, that's success. Any questions on scoliosis specific exercise? I mean, that's what we do most of our day, and it is effective. So, any other questions?
question.
Yeah, shoot.
So, does that, I'm not familiar with any of the specific kind of thing,
Mhm.
but scoliosis specific, is it addressing, like, putting the body in a correct position and trying to, I don't know, strengthen the muscles to make it, help it stay there?
Yeah, you can think about that.
What's
Mhm.
happening? Or?
Yeah. It's trying to reduce the asymmetries that we see, because the scoliosis is causing asymmetries with the rotation, the curve, and the posture forward to back. So it's working on those things and then trying to integrate that into strengthening. So I think that's the biggest piece in scoliosis specific exercise that's missed by a lot of people that do even Schroth method stuff, is that they don't integrate it into life. Because we can take an exercise and have you do it perfectly here in a controlled environment and all this, but if we don't integrate that into things that you do, then it doesn't have as much carryover and it doesn't affect things as much. Does that make sense? So same thing with posture, just general posture. We see kids and adults for postural problems that aren't related to scoliosis. And posture is something that we need to retrain, get them to know what good posture is in a controlled environment, and then challenge their ability to maintain that. It's the same thing with scoliosis specific exercise.
So, like, let's say you do the Schroth method and you learn, like, the proper way to hold yourself.
Mm-hmm.
That means, like, every moment of every day,
No.
you're just going to have to be aware, or no?
No.
Is it going to, like, do it itself kind of when you do the exercises, or are you going to have to, like, be aware of it every moment? Like, I have to make sure I move this way.
So let's see, anybody do like dance or anything like that when they were a kid? Sports, things like that. So let's take free throws in basketball. The more they practice free throws, the better they get. But they're trying to develop a movement pattern so that it just happens automatically every single time, right? That's kind of what we're trying to do with this. We're trying to teach the muscles how to get into correction with as little mental input as possible. And so the less input that we need from the brain, the more it happens automatically. But no, you don't have to think about that every moment of every day, because there's some carryover with that. But if we can integrate that into an exercise routine so that you're practicing it every day, then we maintain that movement pattern that's continuing to help. Does that make sense?
Yeah.
So sometimes when I'm talking to my teenage patients, the look in their eyes is like, oh, I have to do this the rest of my life. And it's overwhelming, right? It's like, so I say, okay, you don't have to do it the rest of your life. You just have to do this for as long as you have scoliosis. So, because there's a spine curve there. It may be unfair that we have to do this long term. And I don't like that we have to do this long term either. But what's the alternative? I mean, yeah, progression, surgery. Surgery will keep you straight, but there's going to be some other concerns with that. Yeah, Janessa.
Just going off of that, I was thinking about this a couple of weeks ago, and there are things that all of us have to do to maintain our health every day that we do. I have to wear contacts. Otherwise, I'm probably legally blind. I will crash my car.
Please wear contacts.
And my contacts don't make my eyesight any better permanently, right? Like it's not healing my eyesight. I still have to put my contacts in every single day unless I want to get a surgery. And it's the same with, scoliosis or other physical therapy. It's part of the treatment. You do it to maintain a healthy lifestyle. You do it to maintain the status quo. Sometimes you're able to, you're able to minimize pain if you have it, improve posture, those kinds of things. Doesn't mean that your scoliosis vanishes, but you're able to continue living your life and to improve your life.
Yeah. Brad?
Two things, because I want to answer your question too. But to piggyback off that, I think that's like a big part of like the program that we do, as well as teaching how to implement this and how to be like, okay, no, you're not going to be a robot 24/7, and that's
walking around with corrections.
But I talk about with my patients, how to implement this throughout your day, and starting with a couple minutes here at a time. And I like to use kind of like this 80% rule of how we get you in these corrections and we teach you how to hold. We're working on this for 10 to 15 minutes, and then after that 10 to 15 minutes, I'll go into, okay, let's find like a 70-80% effort of this that's a little bit more tolerable to hold throughout the day, because we're going to get you in these positions you're like, there's no way I can hold this all day. This is tense. This is very active, right? So we teach those strategies of how to implement that. Hopefully that again answers that question a little bit. And then I wanted to go back to your question about like, how does this work? I like to describe it as essentially we're trying to put forces on the spine that a good brace will do, right? A good brace is going to come in and it's going to push that curve in towards the center. A good brace will also help with that rotational component. And the Schroff method is essentially we're teaching you how to get into a position, how to do a specific type of breathing that's specific to your curve, to put those forces on the rib cage, on the spine itself, and that's how we're trying to prevent that progression, And then with that again comes, about the how it works as far as, that helps minimize the curve, that helps improve long-term posture. Improved long-term posture relates to long-term pain relief. So I like to explain like that. Hopefully that makes sense of like how it's working. It's essentially trying to put those same forces. We're just teaching you how to actively do it.
Mm-hmm. Yeah, and unfortunately, it is a longer-term thing, and I don't think there's any way to get around that. There's no quick fix, and that's actually why I feel like I'm passionate about it. Is because it is something that affects your life for a long time, and there are things that can be done for it. So the exercises that we do, this is one position with Schroff method exercises. We don't do this with everybody, but it's a lot of fine movements and breathing techniques. But again, this isn't that you have to do this every day or sit in perfect correction all the time. We're trying to retrain your body to do that. I think about my ballet dancers that I treat. They all seem to have fantastic posture. They weren't born that way. They were trained that way. And it's kind of the similar thing. So what about core strengthening or yoga? I get this question a lot. And the reason I get this question is because there are people who have scoliosis that are referred for physical therapy. And so they go to a physical therapist, and I would almost guarantee that they do core strengthening. They might do a little side bending to open up the concavity, which is not right. Please don't do that. But core strengthening doesn't do anything for the curve. It's not specific to the scoliosis. If we want to address the scoliosis, we have to do something specific for the scoliosis. Does that make sense? Otherwise, we're strengthening the body in the same asymmetries that it came with. We need to reduce the asymmetries, and then, yeah, strengthen the crap out of that back. But if we can't reduce the asymmetries, then I'm not saying don't core strengthen if you have scoliosis. Definitely do that. But the higher level is getting some correction and then strengthening. So general strengthening, it's not scoliosis specific. General chiropractic isn't scoliosis specific. There are methods of chiropractic that are specific to scoliosis. They don't have as much research behind them, but if you're seeing someone for your scoliosis, make sure that they are specialized and know what they're doing with scoliosis. I can't emphasize that enough. And that's not just because I'm a scoliosis practitioner or because I specialize in that. It's because I see all day long people that say, well, I tried physical therapy. Okay, well, you tried physical therapy. How about we try something that actually works? So but I hear that every day, right? Yeah, I've done physical therapy. Well, what did they do? Well, they had me do planks and bird dogs. Okay, well, that's not specific to your curve. Right? I see some of you smiling. You've done planks and bird dogs for scoliosis before, haven't you? And not that we don't do those, but we need the correction first. What about surgery? We'll talk quickly about surgery because I'm not a surgeon, and it's what we're trying to avoid, but I am not anti-surgery. I want to make that crystal clear. There are reasons to do surgery, and there are patients that I refer to surgeons. But if we can avoid it, let's avoid it. Because, I mean, I think you guys know what the surgery is for scoliosis. It's 2 rods down the back, screws into each vertebrae, depending on where it is. And it limits motion, and there are complications. So if we don't need to do it, let's not do it. If we do need to do it, let's make sure we have an educated way of looking at what that surgery looks like. Curves that are over 45 or 50 degrees or rapid progression that even though we're trying to address the curve, that it's still progressing. Surgery is to stop it from getting worse. If there's significant pain or organ involvement, significant pain, sometimes they'll do that, but organ involvement, if it's pushing on your heart or your lungs or something like that, we want to preserve the organs.
Mine was because my discs had slipped. That's why I had had that
Yeah. So did you have like a fusion,
on the lower part.
a 1 or 2 level fusion type thing? So that's very common, but that's not
Oh, but he didn't correct the scoliosis.
right. So he probably fused the lower part, and now the scoliosis is still on top of that. So that wasn't a scoliosis correction surgery. That was just a back surgery, right? Scoliosis correction is a longer.
He told me there would have been much more.
Yeah. And we have patients that have that, and most of them do great, but it's rough. So there are newer surgical techniques, especially for adolescents. There's tethering, vertebral body tethering, that's actually a good option now if you're a candidate. I think that we'll be seeing more options for adults and adolescents coming out in the next 5 years.
I have a comment, it's not really a question. It says, Emory advised surgery, Duke advised monitoring and waiting for my spine to auto-fuse as I age. I'm a physician and all the differing views are interesting. The surgery has so many complications.
So many complications, yes. That's why we try and limit it. It's really interesting to me that he was told to let it auto-fuse. That sounds That sounds crazy. Because you can't control what position it auto-fuses in. Like, are you going to be fused like this? Yeah. Good comment, though.
So this surgery, you said there's rods, and then what, you just have rods in your back?
Mm-hmm.
Wow.
Yep. And screws into each vertebrae. I mean, it's a pretty intense surgery. Our adolescent patients recover crazy fast from this, but you don't have any motion in those segments that are fused. So that's a big concern, is what happens above and below that fusion, because that has to take up the slack for the movement.
I had a granddaughter, her curve was like this.
Yep.
There was no way, but she had to do this.
Mhm.
And she can play and do anything she wants, just she sits straight.
Her posture's great, right? Yeah. So I would say most adolescents recover, like, in my mind I was saying lickety split, but I don't know how many people know what I'm talking about. But adults, definitely different. And we have seen adolescent surgeries that haven't gone well. Hardware removals, infections, things like that. It's still risks with surgery. For the vast majority of people, surgery is not necessary. It's not that common to get to surgical range. And if you are in surgical range, I think definitely come talk to me and we'll have a discussion on, which surgeons are better than others at that, and what to look for and things like that, because, this is big. So bracing benefits and drawbacks real quick. It's proven to reduce curve progression in growing adolescents, but it hasn't been proven to do anything in adults. I want a better bracing option for my adult patients, and we're exploring that currently. It's non-invasive and reversible, and it can be worn under the clothing. Braces now are actually pretty low profile. It's not like the Milwaukee brace you were talking about with the, this thing. So they're a lot lower profile. The drawbacks, it has to be worn 16 to 23 hours a day, which is a long time, right?
Yeah, luckily she just does it at night.
Oh, she has a nighttime brace.
But they have encouraged her, like, not just sleeping, like after
Right.
dinner, all the way through,
Right.
maximum.
So,
I had to wear mine all day and all night.
Go to school and everything.
Oh, yeah.
yeah. So it's kind of surgeon's preference on that. Like with the 30-degree curve, I don't know her situation, but I'd probably want her in a daytime brace, but that's just me. They're uncomfortable, especially in the heat. They can affect confidence. It doesn't correct the curve, it holds it, and the effectiveness in adults is questionable. Compliance in adults in wearing a brace is really hard because it's uncomfortable. So I wish there was a better option. Spine core, I think, can be an option. It's a little bit pricey, and it's a little hard to fit, but it's I think a better option than a rigid brace.
Yeah.
So bracing works best. This is in the research. It works best when it's combined with scoliosis-specific exercise. So the brace is doing its job when you're not sitting in correction, and your exercises are filling the gap for when you are in correction and retraining the body. So that's how if I had a child with scoliosis, I'd do a bracing and scoliosis-specific exercise together. It's just the most effective that we know. So yeah, any questions on bracing? I'm not an orthotist, so I don't make braces.
So I still have my brace, and it did help me.
Mhm.
Like my pain went away, which was awesome because I was in pain 99%
Mhm.
of the time. But now it's like I get back, and I
Yeah.
still have it. But are you familiar with the spine core brace and know how to do it all that?
I am not that familiar with spine core. I should be more familiar with spine core.
Because my
So.
other guy's like way far away. I have to drive
Yeah.
2 hours to get to him.
I bet Brad could figure it out.
And you what?
I bet Brad could figure it out. Yeah, we could research that.
The brace was $10,000, and I had to pay for it out of pocket, so I kept
Right.
it.
Right.
But
Yeah, you're like, I'm not throwing that away.
but I don't really want to wear it again,
Yeah. So And sometimes is because how long ago was that?
Probably, let's see, I was 20, it's probably been like, I was good for like 10 years without pain.
Yeah. So sometimes the problem with bracing with the brace that you had a while ago is that it may not fit correctly. And so,
Well, it has the spongy things.
so that's why Brad needs to research this and figure that
I
out.
wear like these little shorts that are Velcro on it, and you have
Yeah.
this bolero in the back, and then they rearranged these like
Yeah.
things, and they just rearranged them, and it was uncomfortable and cut the skin, but I wore it for years. So.
The sacrifices we make
It was
for the
worth it.
curve,
Like,
yeah.
if I'm gonna be in pain, not be in pain later, it's not gonna get worse, and I'll do it. You know?
Right. So just hypothetically, if we could get the muscles to do that, we wouldn't cut into your shoulder and stuff like that and worry about putting it on fit. So, yeah, I think we need an option because all of us want something that's a little more passive. We want, for weight loss, we want to take a pill. For exercise, we want to take a pill, although it's not possible. You know, for scoliosis treatment, we want something passive, and I totally get that. But the more we can get our body to naturally do that, I think the less we have other issues associated with it.
I was surprised that when my daughter got the brace at Shriners, they didn't make any mention of adding physical therapy or anything with it.
I am addressing this with Shriner. I mean, I've been here in the area for 11 years, and for some reason, a lot of the scoliosis docs are resistant to sending for that. I think I'm starting to figure out why. They feel like patients won't do it, or they feel like they're just adding a burden to them. Like, why are you making this decision for people? Just give them the option, you know?
Especially if she was still growing over the past year, like, could we have utilized this time better? You know.
I think you know my opinion on that. So I think it's, and maybe next time you see your doctor, ask him that question.
Yeah, I will.
Be like, why was this not brought up? And I wouldn't say, why didn't you recommend physical therapy? Because they're going to say, well, I didn't recommend physical therapy because it hasn't been shown to be helpful. General physical therapy, that is completely true. But why didn't you recommend scoliosis-specific exercise? That's the question that I ask them. Why didn't you recommend the Schroth method? I know all the surgeons, all the scoliosis docs in the area. They know of me. They know what we do. So I think the question would be, why didn't you refer us for that?
Yeah, or give us that education or option.
Or give you the option, yeah. Sorry, that's a soapbox. I'm not going to go off on that one because I will get comments on YouTube for that. Okay, 3 things you can do today. You can practice deep breathing with elongation. So elongation is elongating the spine upward. If you just picture someone grabbing your hair and just gently pulling up and you're following that, but incorporating breathing and some good diaphragm breathing into that, that usually puts you in a good postural position. This isn't necessarily a scoliosis specific exercise, but elongation of the spine, if you have an S curve or even a C curve, will elongate that curve and will create less curve. Does that make sense? So it's kind of like traction, you know, but we're helping against gravity rather than passively doing traction. So deep breathing, diaphragm breathing, sit taller, picture me pulling your hair up to the ceiling gently, not hard, and just following that as you breathe. Does that make sense? We can all try it right now. Any suggestions on ways to explain that?
I think another visual that kind of helps sometimes is thinking about like your rib cage like an umbrella, and you're trying to like open it up, right? Especially where with scoliosis, where you have that concavity, the inside portion of the curve, thinking of opening that side as you're doing your breathing and doing that umbrella thing. And you can put hands on your ribs and kind of feel it happen. But that's a way that you can kind of start getting a little bit more in tune with the breathing and matching that with the elongation.
You're thinking, I tried to learn breathing before.
I only tried it once. Oh, this is so hard.
So with this breathing, we start out very, very easy with our patients. Just try it like Janessa was talking about, like an umbrella opening your ribs. But I mean, if you try it right now and you try just sitting taller, not sitting straight. I actually don't like the term sit up straight, because what does that mean? I mean, if you have a spinal curve, you can't sit up straight anyway. But sitting taller and then adding that breathing onto it. The lungs are a really strong force in the abdominal cavity and the thoracic cavity that will elongate the spine. It's really all muscles, when they contract, they collapse down. So the lungs are actually one of the only things that can elongate the spine.
So I've got two questions. One of them says, is using a teeter a good idea? I imagine that's like a inversion table.
Inversion table.
And then another one that says, if elongating the spine is good, is doing dead hangs a good thing?
So inversion table, have you guys ever used an inversion table? Have you heard of one? I think it can help in pain relief. It's just like doing traction, but it's passive. So when you get back up, gravity takes back over, and I mean, you haven't done anything to train how to hold out of that curve. So I think it can be helpful for pain relief. I don't use it with adolescents like almost at all, just because it's passive. What was the second one? Oh, the dead hangs. We do exercises in Schroth training that is like a dead hang, but I want it to be a little more controlled than a dead hang. We keep your feet on the floor usually. And that can elongate the spine, but again, it's passive. So if we don't go past that into actively correcting it, then we're just doing something passive and gravity is going to take back over. You agree with those? Okay.
Great. I think it's just, again, teaching how to build that control. So I think a dead hang, if appropriate, it's not causing pain in the shoulders, things like that, right? Is a good exercise if you're active, if you're controlled.
Right.
And again, you're utilizing that maybe more for some good pain relief, some decompression of the spine, but going into your active elongation in those gravity positions.
So, yeah, not a bad thing if it's done correctly. So number 2, strengthen your core. So gentle, I like this, scoliosis aware core exercises can definitely be helpful. Keeping your core strong, but not crunches, not sit-ups, nothing where you're really folding into the spine like that. So bird dogs, we did talk about those. Dead bugs, which I have an issue with the name because it's a dying bug, it's not dead yet. And modified planks, things like that where you can keep your back in a neutral position and strengthen your core. I think those are good. Does it fix scoliosis? No. Does it help the pain associated with scoliosis? Probably. If we can incorporate scoliosis-specific correction into this, then we kind of get a double whammy. We get both things happening. So strengthen your core, keep it strong, no sit-ups, no crunches. Going up into that sit-up or that crunch, it maximizes the rotational deformity of the back, and it's not strengthening the right core muscles. Any other reasons we don't like sit-ups and
It's a lot of
crunches?
compressive force on the spine.
Yeah.
Like a lot of compressive force on the spine, more than you think.
Yeah, a lot of compression on the spine. We don't.
Back pain, I've
Yeah.
found that it's usually not a comfortable exercises for my patients with back pain.
I wish they would change it in high schools and schools to do testing. You know?
Instead of a sit-up test, they should do like a plank test or something. I think about just like your core isn't, it's not, you don't do sit-up movements every day, right? Your core is there to stabilize your back, so we should train it the way you're using it.
Yeah. Unless you're getting up out of bed like 50 times a day. Maybe that would work. And then check your posture habits. This is something that I think as we've been talking, you guys have probably been aware of, but notice how you sit, how you stand, how you carry bags. I think being aware of those things is the first thing, and then you can address those. So a couple of examples. How many have children in here? Okay. and how, so with those who have kids and had scoliosis when they were having little kids, most of the time, especially if you have a shift in your pelvis because of the scoliosis, you'll carry the child on that side all the time. Because if you put them over here, they fall off. And so you'll put it on the prominent side hip. Does that make sense? So I'm not saying don't carry your kids, but be aware how often and how long you're in that position, because you're going with your scoliosis curve. If we go with the scoliosis curve, then gravity and the scoliosis are winning, and that's a recipe for progression. Same thing with purses. If you have your purse on the same side every time, and that's, you kind of have to know where your curve is and where, how that might be pulling you, but that could be pulling you and collapsing the concavity. Does that make sense, those things? Even just sitting, a lot of times people will like lean on one armrest of the couch or the chair all the time. So being aware of, are you leaning that way? Are you going with the curve? And trying to mix that up a little bit and changing so that you're a little more in the middle. Does anyone know what I'm talking about here? Yeah? Any other times that you're noticing things like that? Those are kind of the biggies that I see. Even standing, like right now I'm standing on my left leg. I don't always stand on my left leg, but if you're constantly popping a hip, you're probably going with your curve. So trying to address that and stand more equal. So posture habits, and then also with the first one up here, trying to stay tall. Sitting tall, I think, is the best cue that I have for just having good posture. Okay? What happens if you do nothing? If we look at the past, we can extrapolate that for the future, right? Extrapolate's a big word, though. We can see what's going to happen in the future. If your curve is progressive and you do nothing, it's not going to stop. It's going to keep going. If you have pain from the scoliosis and you don't do anything for the scoliosis, it's hard to address the pain. I see a lot of people who will get like spine injections every 6 to 9 months because they have back pain because of their curve, but they're not doing anything for the mechanical problem, so they're stuck in the cycle of needing injections. So don't wait and see. Wait and see is my least favorite thing for scoliosis. That's why I started to specialize in it, because I saw that happening all the time. Oh, let's wait and see if it gets worse. Even in adults, come back to me and we'll do surgery when it's bad enough. That lights me up, by the way, when I hear that, because I'm like, why are we waiting? There is a good option. So just a couple of things that people that we have seen, 14-year-old and a 55-year-old, that see benefits. And I think one of the biggest things is when you have scoliosis, you feel like you don't have any control. You feel like that you're at the mercy of this spinal curve that's in your back. And no matter what you do, sometimes it's like, no matter what I do, I'm going to have back surgery, so why even do anything? Or the pain just keeps going. It's just because I have scoliosis, I just have to deal with it. But we see great results in our adolescents and our adult patients. And that's why we continue to do what we do. And that's why I have amazing therapists that help me do that as well. So key takeaways: you're not powerless. Proactively work on the scoliosis. Surgery is rarely necessary. This is not a presentation saying you need to have surgery, because there are so many steps before that for most people. Scoliosis-specific exercise works. We just have to rein that in to know what we mean by it works. It's not a cure, it's not a fix, but it teaches you how to manage it, and then earlier action means more options and better outcomes. I think that's a big thing. So what I want to offer you guys is, what is that, 3? That 3 is weird. Is it called a discovery visit? The discovery visit is completely free, no obligation, I promise. We're not going to hound you about buying something, but we'll take a look at your specific problem. We'll take a look at your specific curve because, again, we're all snowflakes. Our spines are all different. And we'll talk about what options there are for your curve. It's 30 minutes. I promise you'll walk away with better understanding of your curve. You'll walk away with a path of what you can do about your scoliosis curve. And I mean, really, it's your curve, your life, your choice. I'm not going to force you to do anything about it. But I do feel like learning more about what is going on with your spine is very helpful. And that's the first thing. The first thing we do when we see our patients is we educate them on what their curve is like. And that's, we do that in this visit as well. So we call it a discovery visit because you're discovering what, we'll go with it. And then we can give you treatment options that we have for that. We don't know exactly what we would recommend for someone until we take a look at their back. Like I said before, there's not 5 exercises for every scoliosis patient. Someone might have a mild curve and might just need to tweak a few of their exercises, and they're on their way. Some patients are more involved, and we need to teach them a full scoliosis program.
So do you take x-rays, or do you still get past x-rays, or do you look at the person and look at?
All of the above. Well, we don't take x-rays here. If we need one, we'll send you for one. But previous x-rays would be great so that we can see if you have previous x-rays from a while ago and recently, then we can see if it's progressing, those types of things. We don't have to do this with an x-ray, but if you have them, I'd love that. What we do, so this is actually, if you schedule that discovery visit today, I'll throw in a bonus. We do a topography scan. So if you think about a topographical map, so a map with lines on it that you can see the hills and valleys, that's what this scan does. And it shows us more about the rotation. It shows us more about the pelvic imbalance. It shows a lot of things that an x-ray actually doesn't show us. And I mean, we'll do that during that discovery visit so that we can have as accurate of a picture as possible of what your spine is like. And it's actually kind of cool to, well, for me it's kind of cool. Maybe some people are like, I don't want to see my back. But I think it's empowering to know what it actually is. People have been talking about your spine, maybe not your whole life, since you're 22 or whatever. What is it actually doing to your posture? Where's the rotation? Where's the curve? Where's your pelvis? How is that affecting your pain? Why is the upper trap mad all the time? I mean, I know I'm a little biased, and this is what I do for a living, but I think there's huge value in coming in for a half-hour visit just to get an idea of what's going on. Or if you don't have as big of a curve and you have somebody that, I mean, you said you're related to a lot of curvy people.
Who knows what's going on right now?
Yeah. So, right.
So
I think we'll review x-rays if you have them. We'll review your history. Depending on who your daughter's surgeon is, we can communicate with the surgeon and get more information on the plan.
What kind of a machine does the topography?
Oh, I should have put a picture of that on there.
In your office or at a different?
Yeah, it's here in the office. We just scan it here in the office. And it comes up and we show you on a screen and we talk about what's going on with it.
So let's say you do the Schroth method, you try it out. Like how many visits a week are necessary? How
Good question.
long in general?
So everyone's a little bit different. Usually what we found is about 12 visits over what, 3 months is usually what we're, 2-3 months, to learn it. It isn't the easiest thing to learn. Definitely, I would not learn Schroth on your own. I don't think it's possible. And if you go on YouTube to learn scoliosis-specific Schroth exercises, you'll probably see my videos. But each video, I'm like, don't do this on your own because this is not specific to your curve. So just that disclaimer. You don't know what the exercise that you're seeing online is actually for. It has to be tailored to you. Does that make sense? So
I really have a problem with like knowing. I just don't know.
Like
so
body
hard for
awareness,
me.
spatial
Yes.
awareness.
I
Yeah.
don't know why. It's really difficult for me.
Yeah.
So let's say you learn all this here, and someone's like, okay, that's right, and then you go home because that's the whole point. So you try to do this at home, so
Yeah.
you didn't do it every day or whatever, which I'm willing to do. I mean, I have no problem being persistent. But what if you go home and you try to do exactly what you did here, but
Yeah.
maybe it's wrong? Is it possibly you're going to make it worse, or is it just going to be a little bit not as effective?
I don't think you would do it wrong enough to make it worse.
Okay.
Because, I mean, we set it up in a good way so that it's not like, oh, if you move a millimeter too far,
Yeah.
boom, done. Yeah, Brad.
Well, and to address the concern, like Dave was saying, most, especially, I mean, this is mostly adults here, right? I know there's a couple here for adolescents, but with most adults, I would say about 12 visits is kind of the standard. You know, a little
Yeah.
bit more if you're coming in with some aches and pains or some specific goals of, hey, I want to get into more lifting or this specific exercise, and we can address that. But because it is, you know, a lot to learn, there's a lot of mind-body connection, and that mind-body connection can be really hard. The way to answer your question of how often, we'll see you twice a week for an hour-ish about each visit. And your first 3 weeks are twice a week. You know, if your schedule obviously needs to change, that's fine. But the reason why we suggest that is because you come in, you learn the exercise. You know, we teach you a position that day, maybe 2 later on, but 1 usually the first couple. You go home. You know, you get the equipment to go home with, do at home. You come back in 2 days because you're gonna go home and you're gonna be like, oh crap. Where are my corrections again, right?
Yeah.
So especially early on, we don't have you go too far out in between visits so that you can come back, show us how you did it, review, do tweaks. As you know, sounds like you've tried a few things and that mind-body connection is hard. I think a benefit of coming into the clinic and with, again, therapists who have been doing it for a long time is I feel like we've built skills as far as how to give you specific cues, tactile cues that really help people kind of grasp that mind-body connection. And you'd be surprised at how quickly, even though you feel like maybe right now there's like no way, you'll be surprised at how quickly you grasp onto these exercises. I think most of our patients, and correct me if I'm wrong, in those first 3 weeks, I think by the end of those first 3 weeks, people feel pretty dang confident to the point where then we start to, you know, space out the appointments 1 week at a time, 2 weeks. And we tailor it to you. If you need to come in more, then you come in more.
So last year's SOSORT conference, that international conference was in Croatia last year, which was really fun. But in that conference, they were talking about bracing, and they were talking about maybe we don't need to talk about good braces and bad braces and what types of braces are better. Maybe we need to talk about the orthotist, the person who makes the brace. You know, a good brace is a good brace mostly because the orthotist made it really good. And I think it's the same thing with scoliosis-specific exercise. We might be tooting our own horns a little bit, but the more experience you have, the more we've seen people just like that. You know, where it's like, okay, they're going to need a little more help to learn how to do this. And we know how to do that. It's not like, she's lost cause, you know, because we want that to translate. So yeah, those 12 visits. And then I think the next question is, well, what about after those 12 visits? You've learned the exercises. And in the past, the first 5 years that I practiced, I was like, okay, you know the exercises, let me know if you need anything. And what inevitably happens? Well, they come back later, or they don't, but they did their exercises for 2 months, and then I hear about, 2 years later, they're like, oh, I'm in so bad shape. And so now what we do, we have different options of how we can support you after that. We have like a membership option where you can pay a monthly fee to come in and review for a half an hour each month, and we call you, and we have support groups, and we have stuff like that. Whatever you need to support you in that, because, it's your spine, and it's not going anywhere. And yeah, and you need support with that. So I think, oh yeah, Heidi.
Yeah, I was just gonna ask, like, what are the side effects, I guess, like, from doing this method? Is it normal to feel just like if you did a workout, like kind of tight,
Good question.
kind of stiff, kind of sore, or?
So I actually meant to talk about this, side effects from Schroth. You might get stronger. That's a bad side effect. I don't like that one. Better body awareness. The good things about it, you might have some soreness from exercise, like working muscles that you haven't worked. I'm okay with that as long as it's not like increasing regular pain. Initially, because we are moving things a little bit different, there might be some discomfort, but I don't want that to be on the pain scale really very high at all. Because we're taking everything to midline and to neutral, usually there's not a whole lot of side effects. Like, I don't know, have you guys seen many side effects
Just
that way?
occasionally, if I'm working with somebody with like a lower curve, they'll mention some like tightness in like on the inside portion of the curve, so the concavity. As we're doing the exercise, they'll be like, oh wow, that feels really sore, and I haven't felt it like that before. And it's like Dave said, we're moving things around, we're pulling you out of your curve, putting you into a more neutral, corrected position, and so the muscle's not used to being stretched out like that.
And it's not aggressive.
It's not aggressive.
These are very...
It's usually quite manageable post-exercise kind of soreness.
Right. So just so you know, Schroth was originally designed to be an inpatient treatment. So they would travel to the Schroth hospital, and they would do, how many hours a day? 6 hours a day of Schroth for like 2 weeks. And so that's how it was originally designed. They got great results, but it doesn't really work for our medical system to do that. But when we have patients travel from out of state to see us, which is actually fairly common, when they come in like from Montana or something like that to see us, I actually saw somebody from London one time. They came in and we did 4 hours a day of Schroth for 3 days, so they didn't have to stay here for a long time. Taught them the exercises, and then we follow up with them with telehealth to try and keep that process going. So it usually isn't way uncomfortable because people are tolerating like 4 hours of learning this. The hardest part is learning it, but then the hardest part is consistency. And so yeah. Okay, sorry I went a little long today, but you guys had great questions. Was this helpful to give you some ideas? I would love to see all of you in a discovery visit, me or one of my therapists, because I think there's a lot of value. You're here for a reason. You're here because you have or know someone who has a spinal deformity. And you're here to find out things that you can do for it. I can't give you 3 exercises that fix this, but I can give you more understanding of what it's like and what we do for it. And I think that's hugely valuable. So, any last questions, Yesa?
I do. So, like I said, as far as, I don't know, I guess official scoliosis, I've been told some things, but not extensively evaluated. But the primary thing that I have noticed that I'm curious, I mentioned, is this related to scoliosis, the dowager or something? Is that a scoliosis thing, or is that maybe, but maybe not?
Maybe, maybe not. It could be kyphosis. So kyphosis is the rounding. It's the technical term for the dowagers. So it could be that you have kyphosis and not scoliosis. This scan actually does really good at measuring a kyphosis and showing us what's going on with that. And the exercises are a bit different than scoliosis exercises, but the Schroth method incorporates kyphosis as well, because that's a common thing that goes along with it or is very similar to that. Yeah.
Can you have both?
You can have both, yeah. Some people call it kyphoscoliosis, but that's a little bit of a misnomer term because they called it that because it looks like someone has a rounded back when they have a lot of rotation, and sometimes it's just the ribs are more prominent and their spine is very flat on one side. But sometimes we do see, especially in adults, I think I see more kyphosis with scoliosis in adults, especially as they lose their ability to stay upright. Yeah.
And that's what we'll do in that discovery visit, essentially, is do a screen where, if you're coming in with just like, I have this like suspicion, but I haven't had like an x-ray, coming for that discovery visit, we'll do, a partial assessment, we'll do the scan, we'll talk about clinically what we think and observe, and then more than not, usually what we'll do is, before we start treatment, I always like to have at least like a semi-recent x-ray, or if we don't, we can refer out to an x-ray to confirm if we have a suspicion based off of our testing on that discovery.
Yeah.
That's essentially what that's there for, is to either look at what we already know and show you an option or treatment options, or to do a quick assessment and give an opinion and maybe a referral to an x-ray.
In the meantime, before I see you for a discovery visit, I want you to do these 3 things. Maybe don't go out and do a ton of core strength, but think about that. Check your posture habits, work on that breathing with the elongation, and I think build awareness of what your posture wants to do. So that's your homework. That's your homework assignment. I think that's a good homework assignment for everyone, whether they have scoliosis or not, is be aware of their posture. So if you want to take advantage of that discovery visit option, I think Corey and Brad both have laptops.
I have DP.
Oh, you can do it on there. So they could schedule you for a time. We just need a little bit of information. I think I already have some of your information because you submitted it for the registration. And let's get you set up for a time. And that will be with me, Corey, or Brad. And they're a lot nicer than I am, just so you know. And yeah, if you have any other questions, feel free to stick around and ask those.